Dr. Anil Misro is there with us. I'm requesting him to begin with the session.
Thank you very much. I hope everyone
Dr.
is
Anil
getting a very
Misro, sir,
wonderful
is
time this
probably saying
afternoon.
something. He's also at the scientific chair for this conference.
So, welcome you all. I think we have put together a very nice
Okay, sir, is
scientific
already
program covering the all aspects of coronary heart disease, heart failure, etc. It's a wide spectrum, but rather than being didactic, we have tried to put it in a way that people learn from it. So that's a case-based discussion most of the time. There will be some problem-based discussions, and there might be some other unique features of certain abnormal situations which we'll be discussing, or newer things which have come into heart failure domain. So I think you all will really enjoy it because it's not a simple didactic. You'll really find answers to a lot of problems you face in clinical practice by going through this seminar and this conference over the next 2 days. Dr. Shubhra Banerjee and Dr. Shumit Kumar have worked very hard in putting everything together. And as they said, we have a very international faculty, we have national faculty, and a lot of good young speakers from this part of the country as well. And I hope you all enjoy it. We have tried to cover the whole spectrum, including structural, including the clinical part, including the newer developments, including the, of course, the devices, newer devices which are coming in, and a lot of other things which are related, including some of part of genetics as well. So I know it's very difficult to cover everything in 1.5 days, but we've tried to manage a lot of wide spectrum coverage in a different fashion in this conference. Thank you very much. Please go ahead with the first session, please.
Thank you, sir. And I'm requesting our respected panelists and chairpersons once again to kindly begin with the session for today. May I please request our respected chairperson and panelists, Dr. P.C. Mondol, Dr. Munna Das, Dr. Nobarun Roy, and Dr. Joyanto Sharma to begin with the first session. And the first speaker for this session would be Dr. Mainak Mukhopadhay. We can already see Dr. Mukhopadhay being ready with us, requesting the respected chairpersons to kindly begin with the session. And for this 2 day long conference with you all, I, Chandrima Roy, I'll be coordinating for this 2 day long learning session. Happy learning.
Could we request Dr. Mainak Mukhopadhay to kindly share?
Okay. Thank you, sir. Am I audible?
Start your talk.
Sir, am I audible?
Yes, you're audible.
Okay.
You are audible.
Okay. So thank you. I'm grateful to the organizer and my respected seniors for providing me this opportunity to present my case here. So I have been given a task. I think my slides are visible.
Yes, it's visible.
Okay.
You have to make it full screen. Yeah.
I've made it full screen. Okay. So I have been given a task to talk on a particular case. The case description is just like this. My patient is a 56-year-old lady. She presented to ER with acute worsening of shortness of breath that started 7 days earlier with an heart rate of around 110 per minute, and BP recorded is around 120 by 70 millimeter mercury. JVP is borderline raised, mild bipedal edema with SpO2 of around 84%, and serum NT-proBNP showing a greatly raised amount of 3000 picogram per ml, and echo yet to be done. So I have been given the task to discuss the immediate management of this patient. So my analysis at the initial front will be, this is a middle-aged lady presenting to ER because of some compulsive symptom of acute worsening of shortness of breath. So it is a recent onset progressive symptom, and she's having tachycardia with BP showing no cardiogenic shock right at now. JVP borderline raised, meaning that there is a right heart filling issue, and mild bipedal edema along with raised JVP goes in favor of volume overload status, and SpO2 below 90% goes in favor of desaturation, and NT-proBNP is elevated, that can be truly positive or maybe falsely elevated also, and echo yet to be done. So we know that NT-proBNP is a marker of myocardial stretch, and there are many cardiac causes where NT-proBNP is elevated. We all know the entire chart. And also we will have to keep in mind about the non-cardiac causes where we can have a raised NT-proBNP like advancing age, ischemic stroke, subarachnoid hemorrhage, renal or liver dysfunction, paraneoplastic syndrome, COPD, and some kinds of severe infection like pneumonia and sepsis, severe burns, anemia, and metabolic and hormonal abnormalities like thyrotoxicosis and diabetic ketosis can also lead to increased NT-proBNP. So as my patient is a 56-year-old, so she's in between 55 to 75 years, and as per the guideline, as the NT-proBNP is more than 900 picogram per ml, so naturally I will have to keep rule in the possibility of acute onset heart failure also when I am considering all the other clinical parameters I have been given. So my first impression from this entire presentation is acute onset heart failure. Now, acute onset heart failure can present in 4 different ways. Like it can present in acute decompensated heart failure, it can present in acute pulmonary edema or isolated right ventricular failure, or can present as a cardiogenic shock. So out of these 4, as my patient is having fluid accumulation along with little bit of gradual onset of the presenting symptom, and so that's why considering all these 4 spectrum, my point will go in favor of acute decompensated heart failure. So this is a case of ADHF, and whether for the evaluation of the profile or the hemodynamical profile of the patient, we should know about the symptoms and signs of hypoperfusion. The clinical symptoms of the cold, sweated extremities, oliguria, mental confusion, dizziness, and narrow pulse pressure is not present in my patient. And laboratory parameters like metabolic acidosis, elevated lactate, or elevated serum creatinine I am yet to get. And so I will not consider that my patient is in hypoperfusion, but the word of caution is that hypoperfusion is not synonymous with hypotension, but often hypoperfusion is accompanied by hypotension. So out of this 4 age-old profile, I will keep my patient in warm and wet profile because there is only congestion and no apparent hypoperfusion right now. So what are the stages of management of patients with acute heart failure? Is an immediate, intermediate, and the pre-discharge and long-term phase. So my task is to discuss the immediate. The goals will be to determine the etiology, elevate the symptom, improve the congestion and organ perfusion, restore the oxygenation, limit the organ damage, and also to prevent the thromboembolism. And for this reason, I will have to keep and watch on the vital signs and the grading the severity and the symptoms and signs of my patient to keep my patient admitted in ICU or ICCU ward. And also I will have to take care of the cardiorespiratory function by means of using the vasodilators, vasopressor, inotropes, diuretics, supplemental oxygen, which is necessary in my particular case. And as per the ACC-HA 2022 guideline, again, they have given the emphasis upon the assessment of the severity of the congestion and the adequacy of perfusion, and also to look after the precipitating factors that has caused the decompensation. So the possible common precipitating factors I will have to keep in mind is the ACS, uncontrolled hypertension, atrial fibrillation or other arrhythmias. There can be additional cardiac diseases like endocarditis. There can be infection, which is the common cause causing the decompensation. There can be non-adherence with medication regime or dietary intake, anemia, hyperthyroidism. There are some medications like NSAID or steroid that can increase the sodium retention and cause the decompensation, and also some medications like verapamil causing the negative inotropic effect and leading to decompensation. So for the initial assessment, I will have to exclude whether there is any cardiogenic shock. There is no cardiogenic shock apparently, so I will have to assess for the acute etiology, which is the CHAMPIT, like the acute coronary syndrome, hypertension, arrhythmia, mechanical causes like any endocarditis causing the mitral valve damage, or any valvular heart disease, acute decompensation, free wall rupture, ventricular septal defect. So these are the all possibilities of the acute mechanical causes, and also pulmonary embolism and infection and tamponade that I'll have to keep in mind. So whenever I've excluded these all things, if there is anything present, then I'll have to treat the patient accordingly, or otherwise I'll have to go for the general evaluation and treatment of the acute decompensated heart failure. So apart from the already given parameters, I will go for some bedside evaluation of my patients. So whether there is any presence of pallor, fever, whether the extremities are cold or warm, I will assess the apical impulse, whether there is any cardiomegaly, heart sounds, there can be S3 or S4. And also I will assess for the murmur. Also the soft heart sound is also a possibility, murmur, particularly regurgitant murmur. And if the patient is having preserved ejection fraction, they can have aortic stenosis or HCM or HOCM kind of presentation. Also they can have the ejection systolic murmur, and also bivasal rails, which are suggestive of pulmonary congestion. So basic small steps for a large benefit of the patient are 3, like the upright decubitus followed by oxygenation and the decongestion. So regarding the oxygenation, it is recommended if there is SpO2 less than 90%, which my patient is having, or PaO2 is less than 60 millimeter mercury. Intubation is required when all the non-invasive measures are failing to keep the oxygenation in the place, and non-invasive positive pressure ventilation should be done if the respiratory rate is very high and in spite of regular oxygenation if the SpO2 is still low. But regarding oxygen, the words of caution are there should be no routine oxygenation because it increases vasoconstriction and decreases cardiac output, and also non-invasive ventilation increases the intrathoracic pressure that can enhance the also RV dysfunction, lowering the LV preload also. So the acute decompensated heart failure patient, when there is congestion, I will have to use the loop diuretics, which is the class 1 indicator, and to assess for the congestion relief of my patient. It should be intravenous loop diuretics, and if the diuresis is inadequate, then we'll have to intensify the regimen, or we can also add up. So the class 1 indication is the intravenous loop diuretics, and the combination diuretic therapy is the class 2A, where we can add the loop diuretic with thiazide diuretics. But how to assess for the loop diuretics efficacy? That the initial, if the patient is already on an oral diuretic, then I will have to use the same dose or twice the dose of the oral therapy she is taking in an IV format. Or if the patient is a diuretic naive, then initiation should be done with a lower dose with furosemide of around 20 to 40 milligram IV. Then after 2 hours, we'll have to assess for the urinary sodium estimation. If it is more than 50 to 70 microequivalent per liter, then there is adequate effect of the furosemide is ongoing. Also, we can assess with the urine output, but it should be a little bit later, for around after 6 hours of more than 100 to 150 ml per hour. And if the effect is good, then we can go for this IV same dose furosemide twice daily dose and keep checking on the efficacy of the diuretics, and we should continue it until the complete decongestion is obtained, but keeping an eye on the renal and electrolyte parameters. But if the efficacy, I'm not very sure, if the efficacy is not good, then we will have to double the dose, or we can also add the go for the combined diuretics. Again, the few words on diuretics, that low dose diuretic is always preferred over high dose as per the dose trial, and continuous infusion of furosemide may be used, but no extra advantage is still proved, and must be started with a loading dose if you are using it. Once daily furosemide must not be used because there will be high chance of post-dose sodium retention, and combination diuretics may be used, but keeping an eye on the renal and electrolyte panel. The latest update is in the ESC 2023, the statement on the diuretics in AHF. There are 2 trials been added. One is the ADVOT trial, where IV acetylzolamide has been used along with the IV furosemide, but still the effect was good. But the data is not that a good number of patients, only around 400 to 450 patients. So more data are needed. Again, another is the chlorotic trial, where the IV furosemide been added along with the thiazide diuretics, and again the result was good, but the problem is the renal and electrolyte dysfunction. Regarding few words on the vasodilator, initially in the earlier 2016 guideline, it was 2A, but now it is 2B. So if the patient with acute heart failure with the systolic blood pressure more than 110 millimeter mercury, IV vasodilators may be considered as an initial therapy to improve symptoms and reduce congestion, but it's a 2B. So if your patient is getting adequate relief with IV diuretic therapy, it's not needed, but otherwise it can be added for sure. And the same level of recommendation is by the 2022 ACC-AHA guideline also. And if I'm going to use it, we'll have to use these all 4 drugs. Most commonly, it is nitroglycerin, which is vasodilator, or we can use the nitroprusside, which is veno and arterial dilator along with. Regarding thromboembolism prophylaxis, it is recommended as a class 1A, and opiates is not recommended unless the patient is having severe or intractable pain or anxiety. So family member counseling is also very important because they are necessarily anxious and demanding. We'll have to reassure them and update regularly regarding the clinical status and the plan of the future management of my patient. And most of the times patient, after getting some relief, they try to avoid the admission. So we'll have to explain the family members about the importance of admitting the patient. And also, as the heart failure patients are always a little bit unpredictable from the sudden cardiac death point of view, it is important to explain about them, about the risk of the sudden cardiac death when we are going for the evaluation during the inadmission period. So my take-home message is the initial management of acute decompensated heart failure is a gateway to holistic care, and prompt as well as logical, effective and compassionate approach is utmost necessary. Thank you.
Thank you, Mainak. I think the topic has been well elaborated. We can invite some issues regarding this patient. And our panelists
Dr. Mundal.
Yes.
Sorry. Dr. Mondal, sorry to interrupt. What we do is we would have all the three speakers first, and then there's 15 minutes for
We'll complete
discussion.
the lectures, then we'll discuss. Okay, no problem. Then we can invite the next
So we'll just
speaker.
call the next speaker now.
Yes, yes.